Here's a surprising fact for you. In more than half, yeah, over 50% of all visits to outpatient medical clinics, people show up with, real physical symptoms, but doctors just can't seem to find a clear medical cause.
Wow, over half.
Mm.
That's really something.
Isn't it? So let's unpack this because on today's deep dive, we're really going deep into this fascinating and sometimes pretty puzzling area of somatic symptom disorders. We've got a great chapter guiding us.
Absolutely. And our goal today really is to help you get a proper handle on these conditions because they are complex. We want you to understand what makes them different from other health issues and get a sense of the different things that can influence them. And look, we're going to focus on the key stuff, the main insights, so you don't get totally bogged down. The idea is you come away feeling informed, not overwhelmed.
Exactly. So basically, a somatic symptom disorder means you're experiencing, one or more physical symptoms, and they're genuinely distressing or they mess with your daily life significantly. But here's the really interesting part. It's not just the symptom. It's also about how you, the person, interpret and react to those symptoms.
Uh-huh.
Now, this is crucial. Unlike, say, factitious disorders where someone might deliberately fake symptoms, here, these physical feelings, they're usually not intentional, not consciously produced.
That's a really key difference, yeah. And when we talk about these symptoms, the source material points out some common ones you see again and again. Things like persistent headaches or maybe back pain that just hangs around.
Right, the kind that won't quit.
Exactly.
Yeah.
Or sleep issues, frequent stomach upsets, maybe just feeling chronically tired, like all the time, that kind of bone-deep exhaustion.
Yeah, those can seriously impact your day-to-day, can't they?
For sure. They really take a toll.
And stepping back, looking at the prevalence, the sheer numbers, it's pretty eye-opening. Our chapter says over 80% of people report some kind of physical symptom in just the last week.
80% in 7 days. That really hits home how common just feeling something physical is.
It does.
And what's really interesting, too, is how often these symptoms show up alongside other things, particularly depression and anxiety. It's often not just one thing going on.
Yeah, there's a lot of overlap, it seems. And the consequences, they can be pretty significant, right?
Definitely. We're talking more missed work days, a noticeable drop in quality of life, and unfortunately higher healthcare costs, which makes sense because people are understandably looking for answers, so they might get repeated tests, see different doctors.
That whole cycle of trying to find out what's wrong, the chapter calls it doctor shopping sometimes, doesn't it?
That's the term, yeah. Moving from one doctor to another, hoping for a clear diagnosis. And sadly, there's still this stigma around mental health.
Still.
Yeah. Which means people might be hesitant to think about whether psychological factors are playing a part in these very real physical feelings.
Which leads us right to a really critical point the chapter makes. You absolutely need a mind-body approach here.
Oh, totally essential.
It's not either. It's deeply connected. Okay, so what actually influences these disorders? What are the factors involved?
Well, the chapter breaks it down pretty nicely. Let's start with genetics.
Okay.
Now, we don't have the full picture gene-wise, but research does point to family patterns. Like, you see these disorders in maybe 10 to 20% of people who have a close relative, like a parent or sibling, with somatization disorder.
Interesting.
And studies of twins, especially identical twins versus fraternal, suggest there's a moderate genetic influence, particularly for something called health anxiety.
Health anxiety, like worrying excessively about your health.
Exactly that. A predisposition to be very anxious about health matters.
Okay, so genetics might play a part, make you more vulnerable perhaps. What about the psychological side? That feels like a huge piece of the puzzle.
It really is. One key idea is when people struggle to put emotional distress into words, sometimes the body speaks instead.
Like physical symptoms become the language for feelings you can't express.
Sort of, yeah. It can manifest physically. Also, think about childhood, how parents reacted when you were sick. Sometimes, without meaning to, that attention can reinforce focusing on physical symptoms when you feel bad.
So if complaining about a tummy ache always got you out of school or brought lots of comfort.
Precisely. That pattern can stick. And the chapter also talks about self-compassion, or really a lack of it.
Self-compassion. Being kind to yourself.
Yeah, being kind and understanding towards yourself, especially when things are tough or you feel like you've messed up. Lower levels of that are linked to more physical symptoms and lower quality of life.
So self-compassion is like a buffer.
Kind of, yeah. It helps you handle stress without it necessarily turning into physical problems. It's protective.
That's fascinating. It's like internal kindness can shield you physically. What other psychological factors are mentioned?
Well, there are several things that often come before these disorders develop. Antecedents, they call them. Things like growing up with serious family illness, or getting lots of attention specifically for being sick yourself, or maybe having really overprotective parents, or facing constant high expectations. Trauma's a big one too, like divorce or abuse, maltreatment.
Wow.
Interestingly, before puberty, rates are similar in boys and girls. But after puberty, higher in females. And school stress, that's a big environmental factor too.
So a whole range of early life stuff can set the stage. Now, the chapter mentions a cognitive perspective too. What's that about?
The cognitive angle looks at thinking patterns, specifically negative, distorted, maybe even catastrophic thoughts about normal body stuff.
Like a stomach gurgle means stomach cancer.
Exactly, that kind of leap. Misinterpreting something minor and jumping to the worst conclusion, causing huge alarm. And this idea of health locus of control is important here too.
Locus of control, where you think the control lies.
Yeah. Is it internal? I have some control over my health. Or external? It's up to doctors or fate. People with a more internal locus tend to do better, have less severe symptoms, probably because they feel more able to take action themselves.
That makes intuitive sense. Feeling empowered versus feeling helpless would make a difference. Okay, what about interpersonal factors? Our relationships, social stuff?
Oh, hugely important. Adverse childhood experiences, ACEs, especially trauma, like physical or sexual violence.
Yeah.
They're strongly linked to developing somatization or FND later on. That kind of prolonged childhood stress can actually change the brain.
Really? Actual changes?
Yes, neurobiologically. And even things like being bullied, peer victimization that's linked to more somatic symptoms, headaches, stomach aches, sometimes becoming a way to avoid school, unfortunately.
So it's the emotional fallout, not just direct physical stuff, that manifests physically.
It's exactly. Childhood adversity generally can make it harder to adjust later, lead to less social support, more distress. But, and this is key, the chapter also talks about resilience.
The ability to bounce back.
Right. People with high resilience often report fewer somatic symptoms, even if they've faced a lot of adversity.
Resilience is another protective factor.
Definitely. And speaking of connections, loneliness and weak social ties. The chapter says they can be as bad for your lifespan as smoking 15 cigarettes a day.
Whoa, seriously, that's staggering.
It is. Loneliness is linked to bigger stress responses, heart problems. Lack of good social support just makes stress hit harder, potentially leading to more somatic symptoms. Improving social connections is often part of treatment.
It just hammers home how vital those connections are physically, too. Now, culture. Does that play a role, how these things show up?
It does, though maybe subtly. Interestingly, the overall rate seems pretty similar across cultures.
Oh, okay.
But how it manifests can be culturally shaped. Like in some cultures, talking about physical symptoms might be a more acceptable way to express anxiety or depression than talking about feelings directly.
Right, a different way of communicating distress.
We also see more somatic symptoms in immigrant and refugee groups, possibly linked to trauma and PTSD. And the chapter raises a really thought-provoking point about Western culture. The focus on materialism, individualism, maybe that negatively impacts well-being, potentially contributing to more somatization, especially if we neglect deeper needs like connection, belonging. Think Maslow's hierarchy.
It's like our bodies start signaling distress physically when those deeper needs aren't met. Okay, let's zoom in on specific disorders. First, somatic symptom disorder itself. What's the DSM-5 say?
Okay, so for somatic symptom disorder, you need one or more physical symptoms that are distressing or disruptive, but the key is excessive thoughts, feelings, or behaviors tied to those symptoms.
Like what kind of thoughts or behaviors?
Like constant disproportionate worry about how serious the symptoms are, really high anxiety about health, or spending way too much time and energy focused on the symptoms or health concerns.
Got it.
And while the symptoms might change, the state of being symptomatic is persistent, usually over 6 months. They also add specifiers like if pain is dominant, if it's persistent, how severe it is. There was even a study mentioned on low back pain showing how much psychological factors influence how common it is and how bad it feels.
Right, so it's the whole package, the sensation plus the reaction. What about illness anxiety disorder? Used to be called hypochondriasis, right?
That's the one. Here, the main thing is being preoccupied with having or getting a serious illness.
Even if doctors say you're fine.
Exactly. High anxiety about health, lasting at least 6 months despite medical reassurance. It can lead to either constantly checking for signs of illness
Or the
or avoiding doctors completely out of fear. Interestingly, they're often more worried about the idea or the implications of being sick than actually having symptoms. They might misinterpret normal body noises or sensations as something serious.
And the media doesn't help, I imagine, all the health news.
The chapter mentions that, yeah, health screens, social media, it can feed those fears. It also notes that sometimes if it co-occurs with depression, it might get missed if the depression looks atypical. And surprisingly, in some tough cases, ECT, electroconvulsive therapy, has apparently been helpful.
ECT. Wow. Okay. Let's talk functional neurological disorder, FND, formerly conversion disorder. Sounds complicated.
It involves altered voluntary motor or sensory function. So things like weakness, paralysis, weird movements, trouble swallowing, numbness. But it doesn't match up with known neurological conditions.
So the tests are normal, but the symptoms are real?
Basically, yes. The diagnosis relies on finding clinical signs of inconsistency between the symptoms and medical understanding. Historically, Freud's idea was big stress converting into physical symptoms.
Right, conversion.
Now, it's seen as more complex, biological factors, psychological ones, and often trauma, like childhood abuse. Lots of overlap with depression, dissociative disorders too. And because of stigma, people often see medical doctors first, not mental health pros. So assessing for trauma history is really vital.
It's like the brain is expressing distress through neurological-like symptoms without the underlying disease. A powerful mind-body link. What about when psych factors affect existing medical conditions?
Yeah, that's another important category. It's when psychological or behavioral stuff negatively impacts a real diagnosed medical condition someone already has.
How? Like making it worse?
Triggering it, making it worse, interfering with treatment, increasing risks, even mortality risk. The chapter uses depression affecting the cardiovascular system as an example, or research linking negative emotions on social media to higher heart-related deaths.
Seriously, social media.
Apparently. And general stress work, relationships leading to poor health outcomes. Think Cannon's fight-or-flight stress theory. It also mentions personality types, like type D negative, socially inhibited being linked to heart disease, again highlighting how important social support is as a buffer.
Our minds and emotions really do have tangible effects on our bodies. Okay, shifting gears slightly, where intention becomes key. Tell us about factitious disorder imposed on Self-Munchausen syndrome.
Right. Here, the person intentionally fakes or creates physical or psychological symptoms in themselves.
Why? What's the goal?
The main motivation is to be in the sick role, to be seen as a patient, get that attention and care. Crucially, there's no obvious external gain like money or avoiding work. That's the difference. They often know a surprising amount about medicine. You might see things like wounds that won't heal, weird infections, bleeding, gut problems. In extreme cases, they might go from hospital to hospital, getting procedures for things they've caused.
So the drive is internal, needing to be seen as ill. Very different from malingering, then.
Completely different. Malingering is also faking or exaggerating symptoms, but the reason is a clear external reward.
Like money or getting out of trouble.
Exactly.
Yeah.
Financial compensation, housing, avoiding work, or jail. Malingering is a behavior, not a disorder itself. A kid faking a headache to skip school is a simple example.
Got it. The key is that external incentive.
Right. And you often only know for sure if they admit it or if there's clear proof contradicting their claims, like seeing someone who says they can't walk playing sports.
Clears that up. Then there's factitious disorder imposed on another. Munchausen by proxy. That sounds really concerning.
It is, deeply. Same idea as the first type, but the person fakes or induces illness or injury in someone else, often a child or dependent adult.
Why would someone do that?
The perpetrator, often a parent or caregiver, does it to get attention, sympathy, maybe feel needed or praised for being such a devoted caregiver to this sick person.
Oh, wow. So the diagnosis goes to the perpetrator.
Yes, the perpetrator gets the diagnosis. The victim might be diagnosed with abuse, because that's what it is. It has major legal and criminal implications, obviously.
Truly heartbreaking. Okay, let's switch to how healthcare professionals like nurses approach this. What's key in assessment?
Well, first off, a really thorough assessment is crucial, even if you suspect a somatic disorder. You never want to miss an actual co-occurring medical issue.
Good point.
So nurses look at the details of the symptoms, location, onset, feel, duration, but also, can the person meet their basic needs? Are there safety risks? Do the symptoms seem voluntary? What are their thought processes like? How do they talk about feelings? Also, medications, any history of trauma, suicide risk, past evaluations, relationships, that health locus of control we talked about, and self-compassion levels. It's really holistic.
Very comprehensive. What kind of nursing diagnoses often come up?
Ineffective coping is a common one, maybe related to distorted perceptions or chronic pain with a psychological element, or relying too much on pain meds or anxiety meds.
And the main goals for helping them?
The overall aim is helping them get back to the most functional, fulfilling life they can. So reducing symptoms, boosting independence, improving quality of life, and building rapport, that trusting relationship, is absolutely fundamental, especially since people might be guarded. The idea is gentle guidance towards more independence.
How about communication? Any specific tips there?
Yeah, really important to take their physical symptoms seriously. Acknowledge them. They feel real. They are real to the person experiencing them, even without a clear medical cause.
Okay. Validate their experience.
Exactly. But also gently shift the focus towards identifying and expressing underlying emotions, rather than just repeating the physical complaints over and over. Health teaching should be practical, straightforward, supporting function. Like if one arm feels weak, encourage using the other. If vision seems impaired, describe where food is on the plate.
Little things to maintain independence.
Right. Assertiveness training can help too, using I statements. And exercise regimens good for anxiety, sense of control.
The chapter mentions nurse case managers having a role too.
Yeah, they're key for coordinating care, which can get complicated with multiple specialists. They're a central contact point.
Yeah.
They can help manage healthcare use, maybe fewer unnecessary ER trips if there's regular support, that they provide consistency, advocacy, and help address psychosocial needs.
Sounds vital. What about therapy and medications?
Psychotherapy is often really helpful. CBT, cognitive behavioral therapy, is common. Helps with coping, expressing emotions, finding other strategies.
Right.
If there's trauma history, trauma-focused therapy is crucial. Behavior modification, family therapy, group therapy for social skills, even online EBT options exist now.
Lots of therapy options. And meds.
No specific meds for somatic symptom disorder itself, but meds like SSRIs, antidepressants, are often used if there's co-occurring depression or anxiety. They tend to use benzodiazepines, anxiety meds like Xanax or Valium, less often because of the dependence risk.
Okay, so it's an integrated approach. The chapter had a quick evidence-based practice example, right?
It did. A 30-year-old woman, multiple unexplained pains, wanting help with a denied disability claim. The assessment, past experience, patients could be defensive, research, they might exaggerate symptoms, focus medically, lack psych insight, but certain treatments help. And what she wanted, help with anxiety about the claim denial.
So they started there, with her stated need.
Exactly. Address the anxiety first. The thinking was maybe helping the anxiety would indirectly ease the physical symptoms. So an SSRI and counseling referral was the initial plan.
Makes sense. Meet the patient where they are, build trust. Okay, so as we wrap up this deep dive, what are the absolute key things for our listener to take away?
I think the most crucial thing is these symptoms are real experiences. They're complex. They're influenced by this whole mix of factors, not just physical illness. Understanding that deep mind-body connection is just essential for a more compassionate, effective approach.
Absolutely. Couldn't agree more. And we really hope you, listening, feel much better informed now, but hopefully not too overwhelmed by all the details.
Definitely. And maybe a final thought to chew on. Think about how broader societal things like our culture's focus on materialism or the stigma still clinging to mental health. How might that play into how common these disorders are or how people experience them?
Interesting question.
Yeah, what shifts in perspective, maybe in our values, could lead to better understanding, better support for people dealing with these often invisible struggles? Something to think about. Keep the questions coming.